next speaker this afternoon is also a friend of mine. We went to the Clinician together, PT. He is a board certified specialist in orthopedic PT and also practic PT and a fellow of the American Academy of Orthopedic Mental Physical Therapy. He specializes in treating musculoskeletal injuries, movement disorders, and spinal pain, both acute and chronic conditions. His clinical interests are concentrated in dental therapy and specific therapeutic exercises of spinal disorders. He has extensive postgraduate training in manipulation of the spine and extremities, GSIM, and dry needling. Dr. Harrison Bowen teaches an advanced cervical sensory motor approach alongside with his wife, Dr. Daniel Mohan, in the course diagnosis and management of cervicogenic dizziness nationally and internationally to other healthcare professionals. Ladies and gentlemen, welcome Dr. Harrison Bowen.
Sure. All right, thank you, everyone. So today what we want to do is be able to bring across what my wife and I teach for cervicogenic dizziness, the diagnosis and management of it, from a 2-day kind of course down to about an hour, bringing some highlights for you guys. So really what I want you to get out from today is generally what the diagnosis is and how do we come across it, generally speaking. We're going to speak generally of the vestibular nucleus and the power of what that is. Also the incidence of cervicogenic dizziness, and we're going to talk about the combo of what we have as a double entity or a single entity concept. We're also going to have how we can address this in any PT setting. So what I would like to do, if you can raise your hand if you're kind of more of an orthopedic therapist. Okay, all right. And you go ahead and put those down. How about, would you consider yourself anyone a vestibular therapist? Any vestibular? Okay, a few. How about like neuro? Okay, all right, good. So mostly orthopedics here, and which is very normal. And so we're going to, as you come across today, we're going to show you how this is being combined through different settings as well. Also, I'm going to talk briefly about different barriers that we might have within our different settings, diagnostic barriers and treatment barriers. Really, we're going to go through a timeline towards the end of the session here, just talking about how traditionally this has been treated and managed, and how we're going to introduce a multimodal, maybe kind of a more of a modern approach, and how that is introduced into the future of treating dizziness, sensorimotor conditions, and neck disorders. What I would like for you as we go through this is really what my wife and I have come together and just to combine the manual orthopedic world with the vestibular kind of neuro world. And all these big highlights that we're going to talk about today really are the lump sum of how we can get people better and get them better longer and address them more than just the singular approach that's historically been going on with cervicogenic dizziness. So what I would like for you to start off with, if everyone can, I want you to just look up as far as you can. Check out the ceiling. Go do that. Hold it up there and then bring your head back down and go ahead and do it again. Why not? Try to go as far as you can. Kind of stretch out a little bit. Everyone's just looking on their phone for the last 10 minutes on evidence-based practice, and that's what these teenagers are doing every day, right? Just looking down, even us too. So you can relax now. But generally speaking, when you talk about cervicogenic dizziness, the main provocator of movement is going to be cervical extension. Susan Reed's work, about 59% of the patients in her randomized controlled trials had cervical extension as a provocation factor, and LaHue-Labeur in 2014, you're looking at about 56%. So sometimes we'll get rotation as the main provocator of some sort of symptoms, but I don't know if any of you guys felt something, if you felt a little unsteady, a little off, maybe a little funky, or generally speaking, a little dizziness. So what we talk about when we talk about the diagnosis of cervicogenic dizziness is that it's kind of vague, basically. You're going to get some random adjectives for what someone feels. Taneja in 2011, LaHue-Labeur is a Canadian study in 2014. They pretty much found that these 4 factors are going to be your main subjective information factors for somebody with cervicogenic dizziness. So when they look up, they might complain of lightheadedness or unsteadiness or sense of floating or drunkenness. And quite frankly, it may not even be when they look up. It could be even at rest. It might be with turning their head. But mostly looking up or at rest or turning their head, not as much as looking down. One thing you don't see here is vertigo. And we'll get to that a little bit later with the timeline. So sometimes if someone's coming in, they kind of give you that expression, or that you look up and you get them to look towards the ceiling because they might be having some sort of neck pain and disturbance there. You're doing your clinical screen. A lot of times what we get to at this point is like, well, gosh, Harrison already told me these 4 factors are fairly common in it. Can we make the impression now that the neck is involved? And quite frankly, sometimes we can jump to quick conclusions. When we talk about some sort of head on neck or head on trunk movement disturbances, it's a lot that goes on. It's a lot that goes on. So really, differential diagnosis is the big key when you talk about a condition like this, because quite frankly, dizziness and vertigo, unsteadiness, lightheadedness, all that scary stuff. It's not your tendinopathies and your low back pain, those are your red flags just in general, right? So when we get those symptoms, we want to kind of have our substance up to be able to differentially diagnose and make sure it's nothing else going on, because quite frankly, the diagnosis of cervicogenic dizziness is considered a diagnosis of exclusion, and you're going to get that throughout the literature, because more than likely what's going on is something else is causing these symptoms and not from the cervical spine. And so this is what we consider our optimal sequence algorithm. And when we have to go through and we have to rule out other conditions which are not benign, something as simple or as cervical fracture, and we have pretty good clinical prediction rules with that. Some sort of other central disorder, potentially if someone's had a mild traumatic brain injury or concussion, there may be some other reasons why they're having that way. Or the big one that we always think of is some sort of cervical artery dysfunction. Typically when you look up, you're going to have some sort of occlusion of the internal carotids, right? And rotation is going to involve predominantly the vertebrobasilar, but we want to make sure that someone's not getting those symptoms when they're moving their head. Something we don't really think about as much is cervical myelopathy. Those type of people are going to have some sort of unsteadiness, not as much correlate with looking up, but they might feel a little bit off on their feet. Cervical instability. A lot of these people who might be coming in are potentially post-traumatic. We want to make sure that the alar ligament or the transverse ligament is intact. So when they're looking up, you're not getting any kind of translation of the adductor into the spinal canal or causing some sort of autonomic or sympathetic nervous system dysfunction associated with that. And then for your vestibular folks and neuro folks, really the peripheral disorders are the main ones that we also want to be able to rule out and make sure nothing's going on there, because for the most part, when we look up, we're going to have 3 conditions that mainly involve what we potentially think can be going on. And the first one that really comes to mind is the inner ear. And because when your head is in an extended position, it's going to be a greatly disadvantaged position for the utricles. Okay, so it's just putting them that disadvantaged position, so if they're already let's say weak or perturbed, to have something going on with the calcium or endolymph fluid, then potentially that could fire and cause some sort of mismatch in symptoms as well. Another concept when you look up, we just want to make sure that there is no disturbance in what we call the retinal flap or the image. Is there some sort of disturbance as we go up of the ocular motor system coming in, and we're getting some mismatched systems as we're going up, and they call that the retinal fold. We don't really treat that, but we got to think about that concept. The biggest guy that we really look at, and this is what we're talking about today, is the cervical aspect of potentially having some sort of disturbance going up there. The research has been going on since 1800s of having some sort of disturbance in motor function, ataxia, starting with animals and moving up to humans. That Magnuson's work back in the 70s, and we have some local work going on now as well. So we have a little bit of the what we call the basic science information that there could be something going on. Whenever we look at looking up, we mentioned, or turning your head, we got to be thinking about postural control. We got to be thinking about the multiple sensory integration and the pathways that go on to potentially something causing someone to be at unrest. The big boys that we always think about, the vestibular vision somatosensory aspect. And really what I want to get across today is the neck proprioceptors. The cervical spine has an important role in the proprioceptive input, and we have a huge amount of abundance of mechanoreceptors in the muscle spindles, the rectus capitis posterior minor, major. You got the lateralis there. Longissimus capitis is another huge one that's been associated there as well. So we've got a huge amount of spindles that when you move with some shortening of the muscle, is it providing the right information? That's not including as well as the joint capsules, predominantly C0, C3, that have the most type 2 mechanoreceptors in the cervical spine, right? Most of your mobility is going to come from the upper aspect. Most 50% of your rotation from C1, C2. C2, C3 is going to have a little bit more of a direct pathway into the vestibular system through the somatosensory afferent input there. And a lot of times we'll consider that being the main joint of issue. And a lot of these individuals probably have some sort of disturbance C0, C1. With our forward head motion, we're going to have a little bit more of an extended posture in the upper cervical spine as well. And when we go into cervical extension, the condyles are going to be moving maybe prematurely because we're already in that position there. So the question is you get a couple of these systems that come together, and they provide some sort of afferent input. And these are from your eye movements, your postural control, your head movement control. The big guy I want to bring up here is VN, and that's going to be your vestibular nucleus. This is going to be like your motherboard of your central nervous system that is going to attract signals from multiple aspects. As you can see from this picture here, we talked about retinal slip and the reflexes that are associated with that, the oculomotor afferents. The semicircular canals are going to give a huge amount of input into the vestibular nucleus, as well as some other aspects into the brain, the posterior parietal cortex, and the superior colliculus and flocculonodular lobe. And so you see all these arrows kind of going in and out of this vestibular nucleus. And the way I kind of consider this guy is that he is looking for a sensory matching, okay? He likes things to be even. So if we have our three columns here, one from the semicircular canals, one from our ocular system, one from our proprioceptor signal, and they're coming to me, I'm the vestibular nucleus, I want to get the right signals that are coming through, okay? And if I don't get the right signals, then we're going to adapt a little bit. We're going to compensate. And the compensation could be maybe your body avoiding some of the movements. It could be that we just have this great compensation system in our body. So if something's going on with the semicircular canals and this guy over here is impaired, these two are going to have to raise up their game, right? We got a red card going on, someone sitting out. These two, in order to keep the same mismatch, are going to have to come up and they're going to have to play the game a little harder. So these cervical afferents, if you potentially had some sort of impairments, and then what if you get into a car accident or a concussion, or have some sort of other mild brain injury, or just quite frankly move your head too fast, too wrong, then it's going to make the cervical system work a little harder. It's going to provide some abnormal afferent input, potentially from the somatosensory system, usually the nociceptive signal, because typically someone's going to have some neck pain associated with it, but it's a proprioceptive system as well. So it's determining through the muscle spindles and mechanoreceptors where you are with your head in space. And if that signal is already coming in and you've taken out all the compensation patterns that you've been able to do, and then in the brain, this thing we call the internal model theory of we're getting all these signals, it goes and it's saying, oh, okay, now when I look up, the internal model theory should say, well, I shouldn't feel any restriction in the upper part of my neck this quickly. But now, instead of me feeling that sensation way up here, to get that compression going on, maybe I'm feeling it a little sooner. And so that's what we call the reafference copy abnormality, and basically the combination of afferent input that's being altered by some sort of nociception, a proprioception deficit there, it's not being able to compensate any further. And then we have the alteration in internal model theory, and your brain is basically saying, I shouldn't get these signals. This is not right. And it's quite dumb. The only thing it knows what to do is give you some sort of sensation, some sort of symptom, and that's usually dizziness or lightheadedness or drunkenness or unsteadiness. It's not as straightforward as BPV and something like vertigo. The room is spinning, right? It's kind of the same about muscles. The muscles don't tell you it's tendinopathy. It's just giving you a signal there. And that's where our differential diagnosis from the get-go comes into a play, because we need to make sure that a condition like this, of a diagnosis of exclusion, that the person walking to your office who's not feeling well, who's got those symptoms, we want to make sure that we go through the optimal sequence so we can rule out something a little bit more scary that requires a referral. So a lot of times we'll ask ourselves with this, what could cause this abnormal afferent input, and who could have the cervicogenic dizziness? The way we look at things is we look at it through something called a single entity and a double entity, just like we would with any other system in our body. Tiffany was talking today about hip osteoarthritis and how we might need to be looking at the low back, right? Or the knee and what we need to look at with the ankle, et cetera, et cetera. We need to be able to do this really for these multiple systems as well. And the way we kind of break it down is, if you look at the literature for cervicogenic dizziness, the prevalence rate is in between about 7.5% to about 8.5%. It's not very high. We say about 10%, a little bit less than 10%. So if someone's coming into your office and they're getting some of these symptoms, just knowing the prevalence rate, you'll say, well, that's probably not what's going on, right? It's more than likely something else going on. But I'm going to come across something we'll call a double entity. And this is probably where you're going to see most of your patients with. So we'll take two examples for today's lecture, just talking about the incidence of cervical dizziness and how this really relates to your setting. Most of you guys are in the orthopedic setting, but we'll come across how we're going to see some of these patients just within different ones and how you can potentially get them better even quicker. So the first one we'll talk about is simply neck pain or arthritis. Quite frankly, if you look into the literature, you're going to, even though we in the physical therapy field have kind of gone away from intervertebral disc disease and bone spurs and arthritis and all these terms, right? You're still going to see it significantly through the other professions, predominantly in the medical field, right? There's been a huge influx of research, especially out of China, honestly, just with treating this condition with surgery. And if you read their work, they're making the diagnosis because of X-ray and a correlation of dizziness with some sort of head movement. But one thing we want to get across is that when we talk about a single entity, this may potentially be a huge amount of people that may be at risk potentially who have some sort of cervical arthritis or disc disease, potentially the three systems here that go into the vestibular nucleus. To keep it quite simple there, one of them is already impaired because it's a little bit of degenerative signals coming from that area. So we'll take two studies that really look at this, and this is your first one. This one's going to be all throughout the cervicogenic dizziness in terms of the introduction to the concept and to the research study. And it's a 1996 study by Nikki College et al. And they took individuals over the age of 65 in just a general primary care setting. These people were complaining of dizziness and neck pain, and they really wanted to look and see what the diagnosis and what the cause of it was. Just simply the ones who had the cervical artery or the brain perfusion studies were fine, and the inner ear, the central nervous system was intact through a clinical examination. They found that 66% of these people actually the symptoms would probably originate from the neck, which is pretty high. It's a little higher than your typical 7.5% that we're going to really read if we get into the research studies. That's a classic one. A newish one is Takahashi, and this is out of Japan in 2017. And they did the same thing, but they looked at individuals going to hospital systems, outpatient hospital systems, and they did the same concept. They had 1,000 people versus about 140 in college's study, which is good because that's a bigger N. And after ruling out no peripheral issues, after ruling out the central nervous system or vascular issues, they concluded that 89% of these individuals who had dizziness symptoms had origin from the cervical spine. So this might have implications to you guys if you get into the home health setting and you're performing your balance training because their balance is off, or if you consider yourself a geriatric physical therapist and you're doing balance training, Tai Chi type of approaches in the clinic, or the title of this presentation today, what we call the neck pain or musculoskeletal physical therapy. This is probably what's going on probably in most of your outpatient physical therapy. So we move on from the single entity, and we're going to talk about just simply the double entity concept. And the double entity concept is basically multiple people could suffer from a subtype of cervicogenic dizziness, and that's not the entire reason that they're having these symptoms, but it's part of it. And if you miss part of it, then you might not be getting quite the outcomes that you want to get. The big ones now that come to mind are your concussion and your whiplash, who are now kind of coined together, right, for MTBIs or mild traumatic brain injuries. They're pretty much some similar concepts. Other people with sensorimotor disturbances, your motion sicknesses, their sensitivities, some sort of other peripheral hypofunctions, and possibly your peripheral disorders, your BPVs, posterior canal, anterior canal, lateral canal. We're just going to take one study that looked at the incidence of cervical dizziness in concussion, because that's the kind of biggest, best thing out now. No one really wants to study whiplash anymore. Concussion is the big and best thing. And so, recent study in 2017, this is Jennifer Renica and her colleagues, they looked at the physical examination of dizziness in athletes after a concussion. This is in the old manual therapy journal, or they call it now the Musculoskeletal Science and Practice. They took 41 of these kids, age 10 to 23, and who were diagnosed with a concussion. And they looked and they did examination tools to see what could be potentially contributing to these symptoms. Of course, if you have a concussion, you're going to have some sort of central finding. So 100% of them had central findings. More than likely, you're going to have some oculomotor disturbances, which kind of go along with some of your sensoromotor findings with smooth pursuit and saccadic patterns that are altered. Almost 100% of them, 41 out of 41. But look at the next big thing that jumped up. Before we even talked about altered neuromotor function, peripheral dysfunctions, BPVs, things of that nature, which we typically think about. 8 out of 10 of them, 82.9%, they found some sort of cervical dysfunction. And the way they relay that is pretty much what me and you do in the clinic already, some sort of disturbance in the range of motion, hypomobility, pain to provocation testing, intersegmental testing, things of that nature. And actually 1 out of 4, they actually went further and diagnosed that these kids, 10 to 23, actually had cervicogenic dizziness, which is a pretty high number. 25% of them, if you're getting your concussion folks in and you're not addressing their spine, it might be a huge thing you're missing. It might be something you're missing from treatment of headache, because normally that's what they're going to be complaining of is the headache. But we're talking about more the proprioceptive and the dizziness concept, which we talk about in our courses. You should address and clear that area before you get into improving the altered neuromotor control, the peripheral dysfunctions, and the BPVs. well, BBV first, but in this case, in Jennifer Ernica's words, less than 5% of these athletes had this. So pretty interesting when we get into the newer research there. So this double entity concept may be applicable to you if you're a vestibular therapist, because your docs are probably referring the concussion patients to you. Or if you want to think about concussion as quite honestly a mild traumatic brain injury, what about your other neurological physical therapy? Someone who might have had an ATV accident or something of that nature. Of course, this type of population could be coming into your outpatient. That's your title, the musculoskeletal physical therapist. But how about the kids, the pediatric physical therapists, before we do the single leg work and throw the ball to work on higher level stuff? Maybe we need to clear it. Goes along with the sports medicine folks, and again, a musculoskeletal folks. So in one form or another, we're probably seeing at least some concept of a double entity associated with many of these people. So in the physical therapy world, I think we are doing a pretty good job of having our niches. That's quite honestly what I've done. I've gone down the fellowship route, the manual route, and my wife, who is also a co-owner of our private office, she's the dizziness, she's the vestibular specialist. So, but a lot of times we talk about barriers to treating someone, especially for a vague diagnosis like this that has a lot of controversy associated with it. Sometimes the type of PT that we are may be giving us some sort of barriers. When my wife did her vestibular training, she did it was the Emory training. It was the week long. I think it was probably 20 minutes talking about the neck. That potentially could be a reason for someone needing some vestibular work. As I did the fellowship training, we actually did have a really good vestibular course there. But just from a cervicogenic dizziness standpoint, it was just a little small, minute aspect when you talk about two big higher level training from a regular PT standpoint. So this doesn't include my friends who are home health therapists who are now doing vestibular testing in the home health. They can bill for it now, and it's part of the fall reduction program that we're trying to do. But they don't think about at all the next stuff, and they don't really even think about the canal repositioning kind of concept. They just think of the fall reduction aspect. So sometimes the type of PT in us might limit how we can get people better, because it all depends on where someone goes. And we all know that with what we do. Dr. Beatty's study earlier on looking at a lot of low back. What if the first onset of low back pain, you went to a chiropractor? And maybe they were one of the old school chiropractors, very subluxation based, very much I'm putting things back in place concept. You may be a victim potentially of having the manipulations for the rest of your life without any self-strategies, maybe. Or if you went down the surgery route, and I think we're doing a better job with our direct access and stuff, getting people to come this way. But we know the direction that people go, what type of treatment sometimes they will get. And we just want to make sure that we're putting out at kind of the best of the best stuff might be a combo of some treatment. So I think it's not only the type of therapist that we call ourselves, but really the setting. If you're in a high volume load sports medicine clinic that gets your occasional concussion because it happened on the football field and you've got connections, you may be decent at addressing the sports stuff, getting them to this higher level type of stuff, but just some of the basic patterns of breaking down the upper neck and getting it moving well, getting it feeling better, or even just ruling out the inner ear. It's more than just the Dix, Hall, Pike, and Epley, and you guys who do vestibular know that. Because also the setting you work in, what if you, before we opened our practice, I was in a retirement home for 6 months. Everybody got balance training. These people couldn't move their head 3 centimeters side to side. They would have dizziness, headaches, but by golly, we had to do balance training and lower extremity strengthening because that was what's going to get them better. So sometimes the setting can kind of limit what's going to help some of these people if they have unsteadiness or disturbances with their head or neck to potentially put them at risk for falls. And I think a lot of times it comes down to how comfortable are you treating. I'm a little bit more comfortable with the neck because that's where I went down the path versus, no offense, I just don't like the vestibular stuff. I think it was boring. But my wife is exactly opposite. So we merged together, and it's been good teamwork. And that's really what we try to put across is if you're not comfortable treating, that's what we've tried to do and what we teach to get you comfortable treating it through our approaches. But actually within your setting, it's always good to have someone that if you're the vestibular therapist and someone else is a musculoskeletal specialist, to be able to merge your specialties. We think it's probably best, at least initially, just like we were talking earlier about therapeutic alliance. What if this person has been coming in with, because a lot of times dizziness is going to have headaches, they're going to have neck pain, they're going to have all these issues, and you finally develop their trust to treat them and develop their therapy alliance, but then you send them across the way for somebody to work on their neck that they have no idea who it is. So sometimes it's kind of nice to have some of those skills yourself to be able to do it, or vice versa it's all about therapeutic alliance. We were going to teach in Canada, and they actually turned down the course because it was too manual therapy heavy, even though 16 hours, only about 3.5 hours actually manual therapy, because they said, well, our vestibular therapist would just send them to someone who can treat their neck. And I just was like, this is the exact reason why we need to come up there. But there is that mindset a little bit out there. But just like the incidences we shown earlier, like a lot of these people are going to have both. I think if you can build that therapeutic alliance to get them there, because our biases do affect patient care. That's what we were just talking about with some of the evidence-based work. If you've been trained in dry needling versus manipulation, you're probably going to needle that person. But what if they don't want to be needled, and what are you going to do? You hadn't touched the neck otherwise, you hadn't learned handling skills, techniques, anything to get them feeling comfortable. Because we all have been there. When you have a hammer, everything looks like a nail. If someone's coming in dizziness, we get them started with some habituation, substitution exercises. They're going to do that until we kind of think outside the box. And the same, I think the manual world needs more of the vestibular stuff. Quite frankly, that's what got me going down this route, because there's not, you got to move on and just the passive care. You got to move on to functional movements. And a lot of times when you're dealing with a system that includes the oculomotor system and the inner ear, the vestibular rehab has got some of the best evidence of anything that we can do for conditions of people coming in. So now I'm just going to take you through 2 studies really looking at the treatment of cervicogenic dizziness. And we'll basically use the same 2 concepts. We'll look at a neck pain or arthritis, and then we'll look at the concussion. This is a new study. It's a Ukraine study. I can't pronounce his name. We call him Big J when we teach. Big J and colleagues from Ukraine said, look, let's look at the evaluation on the effectiveness of multimodal treatment for cervical vertigo. We'll get back to the term vertigo in a little bit. So they had 109 patients, ages 18 to 45, and they included these people who had vertigo together with some sort of myofascial pain syndrome of neck and shoulder. About as broad as the inclusion criteria you're going to get with the study, but that's what happens in cervicogenic dizziness studies. The exclusion criteria is the same stuff that we spoke about earlier. This is the optimal sequence algorithm. This is making sure there's no sort of abnormalities in vertebral arteries, make sure there's no blood flow issue going on, connective tissue conditions, right? Instabilities, things of that nature. But I want to bring this study up. It's pretty much a brand new study because what they did, they had 110 people and they put them in 3 groups. The first group, they call it a manual therapy and exercise group. I'm putting the exact words that they have in the study up there because it's kind of interesting when you read the literature from other journals and medical physicians, osteopaths, because they use some terminology that I feel like has become extinct in our terms, such as the elimination. Their aim for manual therapy was eliminating the violated biomechanical pattern of musculoskeletal disorders. I've read tons. We have 600 studies in our book, and violated biomechanical patterns is pretty interesting. So that's their aim in terms of what the mechanisms of manual therapy are. But needless to say, and they added stretching of the neck muscles to improve body symmetry. So they took one group and did that. They had another group and they said, all right, well, let's do that, and then we're going to add acupuncture. And the acupuncture points are listed above. The point of this isn't to look at just those. They had several points, including auricular points, but they also did what we do. It's something called dry needling, which is a subset of acupuncture. And basically they did addition of the impact of dry needling on myofascial trigger points. Interesting, they did another group. The third group was manual therapy, acupuncture, and then they added this vestibular rehab concept. The program included vestibular exercises of the eyeballs, the head, postural exercises, and they gradually increased, just like we would with any other vestibular rehab program, to try to improve the orientation and the perception of the head in space for the most part. The reason I'm bringing this study, because it's the first one, and I've read every single study out there on cervical vertigo that looked at putting 3 different groups in. And I liked it too because when you get into overseas work, they don't really use a lot of outcome measures, but they use the typical 3 that we're going to use in day-to-day practice: the visual analog scale, which is VAS, the NDI, Neck Disability Index, and the DHI, the Dizziness Handicap Inventory. So interesting enough, it was a pretty small study. I only did it 2 weeks, so short-term outcomes. But if we break down to 3 groups here, the first group, needless to say, every group has statistical significant changes, right? And these guys who lectured on that earlier can probably break down some of the statistics a lot better. There's your p-value right there. So I would tell you the study wasn't that great of giving us the information on the statistics, to be honest. But I do want to just bring across 3 things. If you look under group 1, the first day, the VAS was, this is in millimeters, 60 plus or minus 8 standard deviation went down to a 10. That's just with manual therapy over a 2-week span, which was, I believe, 3 visits. Group 2, it went from a 5.6 down to a 3 with just the manual therapy and acupuncture. And the group 3, the intensity of the pain went from 5.5 to 2. So all of them had statistical significant difference, right? Someone comes in and their pain's at 10, and you get down to a 8, right? 2.2 is the minimal clinical important difference. So everyone improved with pain. The Neck Disability Index, which is what we want to improve, right? They're having some sort of myofascial issues associated with that. Same concept. Statistically significant differences the first day and the 15th day in each group. And you can kind of see a little pattern. Actually, the group 3 had a little bit different improvement. Actually, and they said it was statistically significant between the other groups in the Neck Disability Index as well. But the big one that I want to get across is this thing called the Dizziness Handicap Inventory. Because any other study out there, or even you guys who probably work in outpatient clinic are probably doing the NDI, because the person may have a little bit more pain than they do vertigo, dizziness. But I would definitely include the Dizziness Handicap Inventory, because this is just obviously like we want to do, look at the function of how these dizziness symptoms or lightheaded symptoms impact their day-to-day life. And in every group, it improved. The first group, it went from a 39 down to a 12 with just manual therapy. It went from a 37 to an 8 in the acupuncture and manual therapy. But actually, it was a significant, even more significant difference. Actually dropped twice as far from an 8 to a 4 when you added all of them. because isn't that what we normally try to address with dizziness, is some sort of dizziness handicap inventory. So small study, about 35 each. It wasn't quite done. It was only 2 weeks long, but you could imagine probably what it could be with a long-term study if you continue to add the other approaches to improve the head on neck orientation. So that's a single entity concept for the most part, because they basically just made the concept of neck pain associated with vertigo. If we look at something probably you're going to see more in the clinic is concussion. The big study that we bring up others too, is a Schneider work. This is Catherine Schneider out of Canada. This 2014 randomized control trial, basically diagnosis of a sport-related concussion, and he looked at cervical vestibular rehabilitation. They had a control group and an intervention group. The control group got non-provocative range of motion, stretching, postural education, and they said rest until symptoms free, and then they did a graded exertion, which is what we typically do. The intervention group was the same concept, but they added both cervical spine and vestibular therapy. They didn't separate them. It wasn't 3 groups. It was only 2 groups, but they did both concepts. The cervical spine work, it was very vague. They look at joint mobilization to cervical and thoracic, therapeutic exercises of the cervical region and neuromuscular training. In the vestibular therapy, just like we do day to day, they did a progressive habituation, gaze stabilization, adaptation with balance and postural control. The 2 groups looking at them, the group that had the vestibular and the cervical manual therapy were 10 times more likely to be medically cleared to return to sport within 8 weeks. That seems really high to me, 10 times more likely. If you told your patient, hey, if you have this, can I do A, B, and C? It may not fit quite the bill, but you're 10 times more likely to get back to playing your sport if I do this and this, versus someone sending you home with rest and some stretches. I like other statistics. 73%, 11 out of 15 of the participants were medically clear within 8 weeks versus 7% in the control area. That's huge too. 73 versus 7%, same concept there. So basically, Schneider and her colleagues said, this study, we demonstrated a significantly higher proportion of people who were treated with cervical spine physio and vestibular rehab were medically cleared to go back to sport. And they conclude with a combined approach to the treatment of cervical spine and vestibular systems may facilitate recovery and decrease time for individuals with persistent symptoms of dizziness, neck pain, and or headache. So this is just concussion, but imagine what this could be also for your whiplash or your other mild traumatic brain injuries. You guys are probably wondering, well, yeah, it makes sense. You know, this is what we do, which is great. That's what we want to get across. But really, I'm going to go through just quite quickly, how do we get to this point? Because when we look into the literature of cervical dizziness, cervical vertigo, it was never this way. It was never this way. And I think you've and I've got the theme of today, talking about, even from the first lecture with tendinopathy, coupling it with exercise, right? It's getting the better results. Same concept. We're just able to put it 2 and 2 together. And more than likely, the same person who's doing the eccentric training for the Achilles is probably doing the Grasson approach to the calf too. So it's the same person versus doing separate entities. But if we take it through a timeline of how we got here, actually Ryan and Cope was the first one in the modern era to describe neck disorders and dizziness, and that was in 1955. You know, that was even before the Manual Therapy Association in the 70s. Vestibular rehab was just kind of getting out at that time. Between that era, there wasn't a whole lot going on. Our profession was just starting to grow. But a good study that people are actually creating a lot of devices and doing some really cool gnarly stuff with lasers now actually goes back to 1991. This is Revel's work. He was the first to talk about kinesthetic sensibility. And the target that we do to look at joint position error testing actually originated in 1991. 4.5 degrees off of the center was considered clinically applicable for looking at an error in someone maybe having some sort of sensory motor or kinesthetic sensibility test. So if we jump up a couple years from there, Kohlberg addressed, he and his colleagues looked at the postural performance of people who actually had dizziness from cervical origin. So not only are we looking at, all right, well, there's something going on with the neck with some sort of joint position error, now we're looking at posture as associated. About the same time, Cass and Furman were the first to really chat about, let's take out vertigo and just talk about dizziness. Because vertigo is the room spinning. That's what BPV, that's a vertigo, right? These type of individuals typically aren't going to describe that. So about 20-some years ago, we kind of started to separate a little bit of that world, the vestibular world. If we jump 20 years, we know in between that time, that's when we had a really influx of chiropractic studies in particular. These were the ones who were putting out the research on performing manipulative therapies for somebody with cervical dizziness, because the PTs weren't. We didn't address that at all. There was a lot of studies at that time looking at acupuncture as well. 2007 and on, this is where the merge of the manual work and the therapeutic exercise work started coming in a little bit. And this is Gwendolyn Joel and her team really started talking about the influence of the deep cervical flexors and how just strengthening those actually improves dizziness. And those studies are keeping going on and on. Starting in 2008, that's when the randomized control trial with Susan Reed and her work down in Australia. If anybody's read that work, that's pretty much some of the classic stuff that you're going to take to the docs with you. It's the highest level randomized control trials that we have, and it's from physios. And we also have short and long-term results for both Maitland mobilization and Mulligan mobilization with movement for short and long-term effects up to a year. And that's pretty phenomenal stuff. And so you just take about, starting in 2008, showing that, hey, manual therapy can work to improve this as well. And it's not just manipulation, some sort of movement associated as well, or even just mobilizations. They found no clinically significant difference between the two in short and long-term effects, but they show that there was improvement in DHI, NDI, and pain. So we start to see, if you look at the top there, the case reports have changed a little bit from just manipulation to we're doing a little bit more mobilization, some snag work, but it keeps going into some independent manual therapy. Someone's proven a point. She's Mulligan trained. She's putting out that we got to do Mulligan work, which is perfect. But there may be some limitations behind that. If we go in 2011, list that at all. This is the second systematic review. The first systematic review for the use of manual therapy in cervicogenic dizziness was actually from Susan Reed in 2005. And pretty much she said that we need more studies, and which is what stemmed her research from 2008 on, right? But Listad said, look, we're getting a couple of these things in 2011. We know that manipulation and mobilization is effective for cervicogenic dizziness. But they say, if we do vestibular rehab, that the evidence of that with manual therapy is lacking. And in our course, we go over that, and we look at the study, and if you look at the actual studies they put in, not a single one of them did vestibular rehab in the studies that they included in systematic review. So of course it's lacking because there's nothing in there. 8 years ago. We jump up a little bit. About the same time, Julia Trelevian started looking and speaking a little bit more of the sensor motor approach, and her work is going on and booming. So it's really only been about a decade we talk about the sensor motor aspect to improve somebody with whiplash and concussion. And this is about the same time concussion whiplash started to merge a little bit. And a little bit of the work I was telling you earlier with Catherine Schneider and another group, as Cameron Marshall and team. And this is about the same time that concussion got kind of big and sexy too. About 2014, they started to look a little bit more at the role of cervical spine and concussion. And the research was somewhat there a little bit before with whiplash, of course, and the combination of MTBIs. But that's when it really started. So it's fairly new if you think about it, combining the two approaches for something like this. And the whole time now what we're looking at is, especially since Biloski's work in 2009, the effects of manual therapy, right? If you guys ever read that, I think there was an updated one a few years ago. You read it and just talks about local effects, peripheral and central effects, and you get to the end of the paper and you're like, well, it didn't really answer my question. But the whole knowledge of what we do with that manual therapy affects, it's not improving later biomechanical faults, as Big J and them talked about in 2017. But the more knowledge now of manual therapy, and we're also getting a little bit more knowledge in the neuromuscular re-ed, right, with the extensors. And I don't know if you guys treat a lot of whiplash and stuff. It's kind of the same as Dr. Beatty's work talking about today. We have same concept in neck if we do in the back with some sort of fatty infiltration, and maybe potentially specific training to the semispinalis cervicis versus the more local or superficial muscles such as the splenius capitis that may be disturbing what happens when you go into cervical extension and how you can train that better, which could be another aspect of treating these individuals who've had some sort of disturbance in their motor function. And then we jump up. I just told you a little bit about 2017. This is Big J's work. So this is just 2 years ago, talking about the multimodal randomized controlled trial for cervical vertigo. So that's the first one that we've ever had for that diagnosis in particular. The kind of role of combining with peripheral disorders, if you take Martellucci, this is an Italian study out of Rome, just in 2018, they did a study looking at people who needed multiple maneuvers for BPPV, which we call it reoccurrence, and a lot of factors associated with that, right? It could be in a different canal. It could be some sort of vitamin D disorder. It could be water intake, could be nutritional stuff. It could be what he said for the first time in any of my readings, that they found data suggesting reduced cervical spine range motion could require multiple CRPs or canalift repositioning procedures to successfully treat BPV and increase the risk of early recurrences. So if you're having somebody who keeps coming back and you keep dropping them down into the Dix Hall Pike, Epley, knocking it out, maybe something else to worry and observe with the cervical spine. That was just last year. So the question is, like, in the future, we got more effects of what manual therapy is. We want to be able to merge the vestibular work and merge the sensorimotor work and the neuromuscular retraining of deep flexors, extensors. We're doing all that now, and it's just coming around. So potentially the combined work is where the future is for these people. So if you take the title of this study, lecture, Cervical Dizziness, what the musculoskeletal PT should know, I want us to think that it's just not the musculoskeletal. This is what the neuro PT, vestibular PT, geriatric PT, pediatric PT, sports PT, all of us could be addressing what's going on here, or as we call it, just all PTs. And quite frankly, this is what we did. This is in our self-pay office, people who don't get better somewhere else because they're just getting single entities or coming to us for combined work. We had the house, it was divided, we're bringing it back together, we're dropping in the manual, dropping in the vestibular, taking this concept of everything sort of being loose, scattered with the neurological field, postural control, cervical spine, dizziness, headaches, the different entities, sports, home health, balance, neuromuscular, vestibular therapists, and combining. And this is what we call it. We call it the physio blend. We've taken all the works, because when you look at cervicogenic dizziness, you got to look into the ontology work, you got to look into the chiropractic work, the acupuncture work, the PT work, the medical doctor work, and we've combined, because as you saw from Big J's study, that just doing suboccipital releases may not do it. You might could do oscillatory or sustained mobilizations to the neck, maybe T-spine, some soft tissue points which are related to the high density muscle spindles of the upper cervical spine. You don't have to needle it, but you could needle it. Then we take the work of Susan Reed, pain relieving exercises through some of the snags, or maybe the deep cervical flexors like Deborah Fala, Gwendolyn Joel's work. And then we're adding in Julia Trelevian's combined approach of sensorimotor vestibular rehab, but in that order to help somebody kind of get there and get them the multimodal treatment. So what I want the musculoskeletal PT to know for cervical dizziness is that the bridge, combine the bridge. If you have someone in your office, you all work together. That's great. Bridge the gap, bridge the communication of what's going on. Bridge the knowledge between you guys, because you may not be the best. We want to give the A game treatment. We don't want to give the A game vestibular, C game manual, right? Or vice versa. So we want to bridge that knowledge between us and the techniques. And just like we just did with the timeline, especially in the last 2 years to 10 years, the research is starting to bridge a little bit more for us and helping us there. And so then we bridge the innovation to get these people better. I don't know if you need really fancy machines to get these people better. I think it just takes some of the old school principles and put it together with everything we're doing. So I find that some of these complicated neck disturbances, or just something as simple or straightforward cervicogenic dizziness, sometimes it's impossible alone to get there, but if we work it together, it's possible together. Because we want to be able to do more Big J's work and get the best of the best results if we can. And we might have to combine everything to get us there. And combine it no matter who we are, and where we treat, what setting we are in, what our biases are. Because I think the research is starting to merge the biases and bring it all together. Because these people should be seeing the PTs. We have the skill set to do this. We have the knowledge now. We have the research. We have the combined specialties to do this. You're seeing more and more of the research in the physical therapy work, a little bit less and less in the chiropractic work. We have the direct access. People are coming in to see us. And we all know that we can provide the good manual therapies. And then we have the skill set of exercise. That's our foundation to progress these people, even if you look at it from a neuromuscular standpoint, pain relieving standpoint, or a sensorimotor standpoint. I think this is what's going to get you there. So, thank you. Any questions? Cool. Thank you.